Well, first of all, I'd like to say that I've been with the osteopathic profession for more than 25 years. And so far, I have had a very interesting career, both as an osteopathic clinician in practice, as an academic, and as a researcher. And I have to say that my interests in osteopathy started in the early 1990s when I came across a few people, both in Germany and Norway, who were studying osteopathy and who would constantly be talking about osteopathy and who would spend a lot of time demonstrating osteopathic techniques and treatment. And the way they talked about it, the way they did things, it really intrigued me, and it sounded very logical. So it sounded like something I myself wanted to do. So my first step, because at that time I was a physical therapist, so I started reading osteopathy to see if this really was for me, and I got quite enthusiastic about osteopathy. And 1 week after I finished my physical therapy training, I went into to my osteopathic training. So I jumped off the physical therapy profession and went straight into to osteopathy. And I haven't looked back since. It's been the thing which I really enjoy both doing, learning more about, and also teaching. So I really found my home in osteopathy. And I have to say that I think I have been extremely fortunate because my osteopathic career has taken me all over the world. I spent many years in England, working as the vice principal at the European School of Osteopathy in Maidstone, who is a very famous school in European osteopathy. And of course, while being in Maidstone and England, I had the opportunity to work alongside and learn from a lot of great osteopaths, many of them who are no longer among us. And I try to remember them by teaching the principles and the practice that they were passing on to me. Then after England, I went to the United States. I was invited to come work at the Kirksville College of Osteopathic Medicine in Kirksville, Missouri. And of course, this was a great honor for me because after all, this is the founding school of osteopathy and osteopathic medicine. And the opportunity to work at the founding school was something I was very enthusiastic about. So I moved to America, to Kirksville, Missouri, and I spent many years working at KCOM. I was an assistant professor in the Department of Osteopathic Manipulative Medicine. And I also worked as the associate director of the A.T. Still Research Institute in Kirksville, Missouri. So I was exposed to many facets of osteopathy. And again, for the past almost 30 years, my trips back and forth to the United States has again given me the opportunity to work alongside a lot of great osteopathic physicians. Again, people who I have enjoyed learning from and who I respect a lot, and I try to pass on the principles and practices that they were teaching me. And then I moved back to Norway, and since 2011, I have been an associate professor at the School of Health Sciences, Christiania University College in Oslo, which is a full-time osteopathic training at university level. And of course, besides teaching and researching in osteopathy, I'm also still seeing patients because, after all, osteopathy is about making patients better. So I would say that I've been very fortunate because I've been able to explore osteopathy both through the European perspective and also through the American perspective. And the way I understand osteopathy today, the way I teach and the way I practice osteopathy today, I think is a culmination of all those experiences. And I have to say that I've always been curious. I've always been open-minded in the way I do approach osteopathy, and I try to take all of these experiences that I have had and organize them and systematize them into a teachable system, didactically speaking. So that is the essence of most of my courses, actually.
You have a common part with a lot of Italian osteopaths, because you are first a physical therapist and then an osteopath, like a lot of osteopaths in Italy. If you can just recap a little bit your way to work, how do you use the osteopathy in your office with the patients? Just a little talk about your way to work.
Yes. I will try to summarize that, because again, the way I work is reflected in the way I've organized my courses. And I'm not an osteopath who tend to think of myself as a structural osteopath, as a visceral osteopath, as a cranial osteopath, or as a fascial osteopath. First and foremost, I am an osteopath, and I think the only way to properly apply osteopathy to patient care is through integration. So in essence, when I start with the patient, having done the case history, the most important thing for me is to try to understand what type of osteopathic approach do I think my patient will benefit from the most. And when I think about osteopathic approaches, again, they are not technique dominated, but they're truly different types of approaches depending on the assumed need of the patient. So in my world, I have divided osteopathic approaches into three main approaches. That would be more the symptom-based approach. That is something which I would typically use on patients who do have more a acute pain presentation, or even patients who do present with systemic dysfunctions. For instance, in the cardiovascular system, eye, ear, nose, and throat, respiratory system, gastrointestinal, or urogenital system. So basically, I'm focusing more my approach on targeting the symptoms and the pathophysiology behind the symptoms through a more regional approach. So if I think this is what the patient will benefit the most from, this is where I would start with my patient. The second approach which I use is what I refer to as the minimalist approach. When I talk about a minimalist approach, it doesn't have anything to do with spending little time with the patient. So it's not about that, but it is about doing a thorough global osteopathic assessment of the patient in order to highlight the regions and the tissues of the body, which I do think has the greatest impact on the functional organization and the physiological capacity of the patient's body. So I would probably then spend about 80% of my time with the patient assessing the patient in the standing position, in the seated position, lying down, including all the systems, the musculoskeletal, the visceral, fascial, the cranial, and so forth. Trying again to highlight the tissues and the regions I think are most significant for the presentation of the patient, which is basically trying to identify what some people would call the chain reaction in the patient, what the older osteopaths used to refer to as the key lesions, if we could still use that term. I prefer to talk about those dysfunctions more as the areas of greatest restriction with the biggest impact on functional organization and physiological capacity. So that's the minimalist approach. But again, that's not something I can use on all the patients, because it does have a very, very important requirement in order to be effective. And that is that the patient needs to have physiological reserves in order to respond to my treatment. So that's something which I would probably use more on a subacute patient or a chronic patient which do still have physiological reserves. When I use the term physiological reserves, it means that the allostatic load or the allostatic overload in the patient is not yet too high. So the organism, through its self-regulatory mechanism, can respond to my treatment. So that's the minimalist approach. It's heavily invested in assessing the patient, finding the tissues and the areas in the patients you need to treat in order to improve the condition. Then we have the maximalist approach. The maximalist approach is also a approach which does have a long history in osteopathy. But again, here we would typically apply the maximalist approach to patients who do not have the physiological reserves to respond to treatment. So the objective of my treatment is to more support the body physiology back towards normal in my patient. So rather than spending most of the time assessing the patient, trying to find the key lesions, we're turning the coin around here. And we are then moving through the body of the patient in different types of treatment sequences in order to try to support body physiology back towards normal. If we look at maximalist approaches in osteopathy, I tend to say there are three major maximalist approaches which has been taught. The one which in Europe is most common is probably general osteopathic treatment or total body adjustment, going back to Little John and John Wernham, in which you attempted doing mechanical and physiological integration by articulating your way through the patient's body. A second maximalist approach is, in my view, the work of Roland Becker when he was teaching his diagnostic touch sequence. And again, you could see he was working his way through the patient's body, establishing different fulcrums in order to support body physiology back towards normal. And you can see already here that we're at the opposite end of the technique spectrum because again, GOT or total body adjustment is using more a structural approach to treating tissues, whereas Roland Becker would use more a indirect approach to support the healing mechanisms of the patient's body. So approaches are not technique dependent. Then we have the third one, which is the one I tend to base a lot of my work on, which is the ideas of Dr. J. Gordon Sink, who was an American osteopathic physician, who was in his clinical practice inspired by all the great osteopaths. And he was also very pragmatic in his approach, trying to restore body homeostasis. Out of his work grew what we call the respiratory and circulatory model of care, where the objective of treating the patient's body in a sequence using all types of osteopathic techniques is to decrease the workload of breathing in the patient. It's to open up the fascial pathways for fluid returns or removing obstructions to fluid returns in the patient's body, and also to augment fluid returns through different types of osteopathic manipulative procedures. And of course, besides having a major effect on respiratory capacity and circulatory dynamics, we also see that this type of approach do have a lot of biomechanical and postural effects on the patient's body, as well as neurological effects through the autonomic nervous system. And it's a very integrative type of approach. It's really nice and it's very fluent using it in clinical practice. And it's really open-ended in terms of the types of techniques you will use on your patients. And it's really one of the approaches which has helped me in practice over the past 20 years to understand truly the concept of integration. So I really, really love this approach, and that is what I, among other things, teach in my my maximalist course. So that's basically what I'm trying to do: understand my patient and think about what do I think this patient do need: a more symptom-based approach, a minimalist approach, or a maximalist approach. And I can also, of course, wander between the approaches as the patient is progressing or not progressing, where I might have to change my strategy in order to help the patients. And this is really what I love about osteopathy, because it's then all about the patient and not about me and my preferences as an osteopath.
Yes, thank you very much. You have talked about a very nice way to see the osteopathic way to work. And during your talking, your description, you already introduced the part related to the school, because we were talking. We want to talk about a little bit about the courses that you teach in Advanced Osteopathy Italy Institute here in Italy. And with your description, you already talk about the maximalist course, the minimalist, and the symptom-based. If you can make a little focus about the systemic approach in the patient.
Absolutely. And again, as I said a little bit earlier, what I try to transmit through the courses, through the osteopathic approaches, it's the tradition of osteopathy, building a bridge from theory and practice to clinical practice, and also integrate it with new developments from the side of research. And a lot of these things which I do teach in the courses are not taught generally in undergraduate osteopathic education. So I feel it's a little bit my mission to continue teaching those, to pass this knowledge on to other osteopaths, and also to help them sort of bring a lot of their ideas together. Because I think that a lot of people, when they go through the undergraduate training, they know a lot of techniques, okay, but there seems to be a lack of understanding how to put this all together. And this is really what I'm trying to do when I teach the minimalist, the maximalist, and the symptom-based approach in osteopathy. And of course, when we talk about the symptom-based approach, it's not all about the acute pain in the patient, but it's also about patients with systemic dysfunctions. And if you think about systemic dysfunctions, we may have patients who are presenting with symptoms in the respiratory system, in the cardiovascular system, eye, ear, nose, and throat, the gastrointestinal and the urogenital system. So the whole objective of that course is to teach the principles on how to try to focus more on the patient and address the pathophysiology behind the symptoms rather than targeting the disease. When I talk about addressing the pathophysiology here, we are primarily using in constructing the treatment plan for the patient the autonomic nervous system. We are using the lymphatics and a little bit the venous system, and of course also respiration. And then trying to tailor the osteopathic treatment of that particular patient around those systems in order to influence the pathophysiology. When we have completed the course Osteopathic Considerations in Systemic Dysfunction, which also has a lot of theory on the neurophysiology here in order to sort of bring it up to speed, everyone is capable of applying that immediately to the patients. So if they do the course, they come back on Monday in clinical practice, there's a patient presenting with headache, low back pain, and irritable bowel syndrome. They should immediately be able to use the principles from the course to address the symptoms in that particular patient. And this is also a objective which is crucial to me, is that every course, everything they learn in every course I teach should immediately be applicable in clinical practice. You don't have to do step 1, step 2, step 3, step 14, step 15. No, each and every course is geared towards helping them immediately in practice.
Good. Very clear. Very clear. Just a few minutes talking about the other courses you kept in our school. If you remember the approach, the osteopathic approach to the fascia, then you kept a course about form and function. Do you remember? And if you just spend a few words on these courses, the contents of these courses.
Absolutely. And we could also, of course, add on the masterclass in high velocity here, because again, this is something we do.
Yes, I want to keep it for the last part.
The last part.
Yeah.
Okay, well then we'll wait. Well, Osteopathic and connective tissue continuity is really the course which is focusing on the fascia of the human body. And again, I think looking at the fascia in isolation is a big mistake. But again, what I try to do in that course is to look at the anatomy and physiology of the fascia and integrate that into the function of the patient's body in health and disease. And it's a course which is heavily vested or invested in anatomy and physiology, where we follow the connective tissue continuity basically from the base of the skull all the way down to the pelvic floor and into the extremities. And we use then a anatomical and physiological approach to try to understand how we can integrate and treat the fascia or the connective tissues of our patient. Again, this is a course which is based on a long-standing osteopathic tradition. So I tend to integrate a lot of different ideas when teaching practically that part of the course. We'll recognize work here again from William Neidner, Robert Ward, John Peckham. There will be work from Tony Chila, and a lot of these osteopaths who devoted most of their career to developing osteopathic approaches around connective tissue continuity and the fascia. But again, the main difference would be that we have learned so much new things about the fascia through the works of people like Frank Willard and so forth in the past 20 years. So I also try to update the course by keeping it up to date on anatomy and physiology. And again, it is to help the clinicians better understand how they can use the fascia in different types of clinical presentations to help alleviate the problems the patient is presenting with. So that is what we're doing in the fascia course. And the form and function is actually building more or less on that, where I introduce probably the lesser known approaches to connective tissue continuity and the form and function of the body to the osteopathic students. It is probably also the most subtle course I do teach, and we're looking at many different perspectives and aspects of addressing these issues beyond the more traditional means in osteopathy. So that's the form and function course.
Yes, I remember. Then we go through the end of this interview, and just the topic is the master on the HVLA techniques course, and then the brand new courses that you kept in the last month in advance, the women health and the osteopathic structural clinical examination.
Yes, so
just recap these courses, the contents.
Yeah. So if we start with the high velocity course, it's a 2-day masterclass on high velocity techniques, and I tend to think of it as a tour de force of high velocity, where we do visit a lot of different HVLA approaches from both Europe and the United States. I tend to have a more pragmatic approach to teaching high velocity, and my main objective is to help the participants getting comfortable doing high velocity on patients in different sizes, in different positions. So that is the main objective of that course. I don't think I do teach a lot of fancy stuff in that course, but I'm really focusing on trying to help the participants understanding and being able to apply the principles of high velocity by looking at patient positioning, operator positioning, handling of the patient, localization of forces, and activating forces, in order to understand how they can effectively apply high velocity in a painless manner to most patients they're seeing in clinical practice. So that's the objective of that course, and I do enjoy very much teaching that too, as I do with all the other courses. And then one of the new courses we did last year was the osteopathic structured clinical examination, and this was basically going a little bit back to basic, where we looked at the musculoskeletal system. For each of the regions of the musculoskeletal systems covered, we were looking at the applied anatomy, we were covering the pathophysiology, and I really spent a lot of time updating the concepts in order to make sure that the participants were getting the latest knowledge when it comes to pathophysiology of the different body parts covered in the course. And then based on that, we were building examination routines of patients for the different body parts based on the principles of both orthopedic, neurological, and functional assessment of the patient. So it's not only to build up good routines for assessing patients, but also to update your knowledge base on the pathophysiology. So that was one of the courses we did last year, which was a new one. We also did a course on women's health, which is a topic I do teach also elsewhere, among other places with Renzo Molinari. And again, we spent 3 days looking at the osteopathic approaches to women's health, where we explore the principles behind our approach to women's health. And then we started working our way through different concepts relevant to women's health based on anatomy, physiology, and pathophysiology. And of course, also the clinical practice going with that in order to help those patients. So we were covering a lot of subjects. We were looking at the pelvic basin, the content of the pelvic basin. We were looking at the pelvic floor, the organs of the pelvic basin, symptoms associated with that. We were looking at intra-abdominal pressures, pressure distribution. We were looking at the venous dumping syndrome in patients. We talked about the pregnant patient, and so forth and so forth. And again, the main objective for me was to give the participants things which immediately could be applied to those patients' population in clinical practice. And the last new course, which I don't think I've been teaching with you guys before, is of course the still techniques, which we are doing in May. And that's also one of my favorite courses. And I have a more than 20 years of history teaching the still techniques. And the still technique course is, of course, a reference to the principles of manipulation employed by Andrew Taylor Still in treating patients. And that is a course which really has evolved over the years. The first time I really formally taught that course was in Arizona at Midwestern University, together with Richard van Buskirk from the States, who also does the still techniques. And we were doing a compare and contrast course where we went through the different body regions. He was showing his approach to the still techniques. I was showing my approach to the still techniques. And then we had all the participants chime in in the discussion. And I can tell you, the course participants back then in this course were people like Robert Kapler, Tony Chila, Phil Greenman, and all the old timers who were still around practicing osteopathy. So we had some really nice discussions. I've also done the same thing with another American osteopathic physician by the name of Dr. Jerry Dickey. We did that in England about 10 years ago in the same fashion. And based on all the work with other people, based on interacting with a lot of the old timers, both in England and in the United States, I've come to the conclusion that the still techniques is really centered around 3 different treatment principles, really. And that is what I'm teaching in the course. And those who attend the course, they will learn how to address dysfunctions through the principle of challenging the barrier, which is the direct type of still techniques. They will learn the balance and hold, which is more the indirect type of still techniques, and they will learn the exaggeration of deletion, which is a combined still technique. They are super effective in managing different types of tissues in the patient's body. They are very gentle to the patient, and it is probably one of those types of techniques which I use the most now when I treat patients. So the whole course is based around giving the participants the history of the still techniques, the principles of the still techniques, and then the practice of the still techniques through all the body regions. And as I said, it's a really fun course, and you will learn a lot of very neat ways of addressing dysfunctions in different types of body tissues. So that's the still techniques.
Great. Thank you very much.